Hey, good morning, everyone. I'm Fabio Lima, the structural heart fellow at UCSF. I'm here with Dr. Jonathan Schwartz from Atrium Health in North Carolina. We're here at the CVIS meeting, and I wanted to catch up with Jonathan and pick his brain more about ICE. He just had a great presentation yesterday on the use of ICE in structural heart cases. And lately, we've been having some big news from the FDA with the approval of VOC and now TriClips coming through the pipeline.
Yeah.
So I'd love to hear your thoughts more about this.
Yeah, very exciting. Great to be here in Tucson. And this has been a growing meeting, and we're always talking about sort of the latest and greatest technologies. So both of them, 3D ICE has sort of been out for a little less than a year now. It's still kind of been a slow rollout just because of the manufacturing. And I think companies want to make sure that the places that are using it are sort of really getting a handle on things, and then they can use those people to sort of train the other ones. Mm-hmm. But the ICE is already, even in its, the 3D ICE in its sort of infancy, has become a key part of all these tricuspid procedures. Like, you still do need TE, but it really adds a lot to the procedure to be able to sort of have your imaging be right above the valve where you're trying to look at while you're doing the implantation of these devices.
Oh yeah, I mean, I personally, in the few cases we've done with TriClips and seeing how this device can come over that valve, to your point, and just give you images that the TE can't, because the valve is so much more anterior compared to where the mitral is in the back of the heart. It's really just changes the whole momentum of the case and everyone's comfort level with what they're seeing.
For sure. Yeah. I mean, before ICE, we pretty much have done most of our cases with it, but there were a few that we didn't have 3D ICE yet. The case length has been significantly improved.
Oh yeah, for sure.
And also the sort of the reassurance as the operator, being able to see the leaflets go right where they need to go for these devices, it just really helps.
So there's a few ICE catheters now on the market.
Mm-hmm.
And they're all marketing this 3D or 4D potential, or whatever the 4D aspect is of it. How do you feel about like the different types of technologies that are available with ICE? And do you have any particular like ideas of like where the 3-dimensional really helps versus you really don't need it?
Yeah, so that's sort of what I talked about yesterday. That's a long conversation, but we can sort of go into a little bit of it. There's 3 main ones. We've been lucky enough to use all 3 at our site, which has been great. I don't think that's practical. I think in general, probably going forward, like a site should really pick one that they like and then just stick with that.
Yeah.
The differences are minimal. They are still all first generation devices, and so I do anticipate as we get a little more progress in engineering, we can sort of dial them down and improve things a lot. But minor differences in the sizes of the catheters, the capabilities are all pretty much the same. Some of them offer a little wider field of view. In particular, the Philips catheter is probably the best for that. The color Doppler and the frame rates are all a little different with each one. Again, Philips is probably the leader there. The other big thing is sort of the workflow, the way these connect to the machines in the room. Some will work with your existing echo machines. Some need a dedicated machine. I do think going forward, they'll probably all work with like your normal echo machine. It just sort of makes everything a little bit easier. But learning is also something that they're really working on.
Yeah.
Protocolizing, that's probably where you're going.
Yeah, that's what I was going to ask. Because we are interventional cardiologists, and we're very comfortable looking at fluoro, and we look at TEs as well. But the actual doing, the moving around of the catheter, rather the probe itself for imaging, that's a skill set that our echo colleagues really mastered. So it's on us to start becoming more comfortable with this. But how do you feel about having an echo colleague in the room where you're having an ICE-driven procedure? You love their expertise, I'm sure, but it's also you want to learn how to get your own images.
One, I guess I'll say first, you're lucky that you're a fellow learning this all at the same time, because I think it's been a little bit of a struggle for some interventionalists when they've been so used to just depending on TE. You don't have to worry about the echo side of things, and then now it's sort of falling into their hands. And so there is a bit of a learning curve with ICE, but I think if you're persistent and you have like a sort of a protocolized approach to it, you can learn it.
Yeah.
Too bad. Initially, it was sort of interesting when we first got it. We weren't sure exactly how it would work with the dynamic between the interventionalist and the imager in the room. We even had a couple cases where the imager would scrub with me and sort of manipulate the catheter, and then we just had a sonographer run the machine. That didn't really work that well. There was just too many cooks in the kitchen. And sort of over time, I mean, a lot of interventionalists do have some exposure to 2D ICE, and so the manipulation of the catheter isn't too hard. 3D just adds one little extra layer of it, but you learn where it needs to go. In general, the probes are getting to the point where there's 1 or 2 positions you need to put it in, and you can just leave it there. and the innovator sort of goes and runs with it and gets the pictures that you need.
Yeah, for sure. I agree. Especially on the right side, you can kind of just, once you find that sweet spot, you kind of just leave it. And now with the newer devices, you can rotate the probe's image without having to, by hand, just ask your echo tech to, change the omni on it, and it saves you from like moving this thing out of place and then losing your orientation.
Exactly.
So it does make life a tad bit easier.
Yeah. And I think you asked earlier about 3D. That's another place where the 3D really shines, particularly in your Watchman or amulet cases.
Yeah.
When you're putting the device in the appendage and you're looking at, is there apposition around the whole thing? Are there any leaks anywhere? 3D offers you can just do one acquisition and then go back and do measurements and assess it.
Exactly.
It saves time. I think it's probably more thorough than if you had only 2D. So.
Yeah, there's definitely this learning curve with ice, but then there's like another level to it with that. You want to be comfortable on the right side, comfortable with ASDs, comfortable with your PFOs, comfortable even with your tricuspid, and then cross that septum over to the left side, because it's a very different game on the left.
And it's nice because that's a great place to start. If you've never used ice before, try it with PFOs, ASDs, maybe even have an imager in the room. Do it with both. Use a TE and an ice probe at first. I think it's a great way to sort of get your feet wet, get comfortable with the maneuvers, and then the next step would be more complex right-sided procedures, tricuspid stuff, and then crossing the septum sort of adds one extra layer. So
yeah, and I'm sure if one day we evolve to the phase that we don't need to be intubating these patients to put TE probes down all the time, I'm sure the patients themselves will like that. It's one less risk factor on the table, and the anesthesiologist will also probably feel more comfortable. They can wake the patient up faster, and things will run smoother.
Yeah. It helps with your workflow, gets patients home faster. You can do more cases per day. Yeah. That's one of the number one things patients say when they come back after Watchman's is it was so nice. I had minimal sedation. I went home the same day.
Oh, I bet.
That was great. The other thing is I do wonder if in the future the engineering will be good enough that we won't have to cross the septum anymore, that you'll be able to view.
I know. I think about that too. Yeah. Some people talk about putting in the pulmonary artery, that you can actually get some good visual aspects of the left side when you're in the PA, but it's exciting times. So there's a lot of moving parts here, and I'm looking forward to what CVS is going to have next year on talks about ice and even tricuspid valve disease.
We've already sort of expanded the bounds of the procedures that we're doing, and I have a pretty cool case where we put it in the aorta for some leaks.
Okay.
So maybe they'll let me show that next year.
That's really exciting. Oh, well, thanks so much, Sean.
My pleasure.
Thanks, everyone.
Thank you.